Assalamu alaikum. First of all, I would like to thank the organizers, Dr. Askar and Dr. Absi, for the invitation, and thank you, Mr. Germans, for the introduction. So for the next 20-25 minutes or so, I would summarize the frontline therapy for patients with CLL. So this is my disclosure. These are my agenda. And this is the timeline, you know, with the improvement in the diagnosis and risk stratification of patients with CLL and the introduction of novel therapy for patients with CLL. And over the last 5 or so years, all of these novel agents, including BTK inhibitors and BCL2 inhibitors, went for patients with CLL. So to get you back to the risk stratification of patients with CLL, this is an old, since 2016 was published, the CLL IPI. They got the 2 sets of a training and validation set of more than 3,400 patients. And from this data, they get a training and validation set that they compared it with the external set, and they identified 5 variables that were significant, and they did stratify patients to 4 groups: low, intermediate, high, and very high. And all of these risk groups were calibrated from your right-hand side with overall survival. And also into the risk stratification, they included patients who didn't respond to perinalog. This is at the time of chemotherapy, and those relapsing within 24 months after the chemotherapy. And the risk factors during the targeted therapy era, they classify patients to 3 groups: standard, high risk, and very high risk, including patients with 17p or TP53 mutation. And when you consider what factors you would consider when you want to treat your patient, definitely we treat patients when they are symptomatic and there is an indication to treat. And it's very important to take the patient's and disease characteristics. So from the age of the patient, the presence of comorbidities, the therapy available, and the patient preference, of course, the prognostic features of the patient, genomic features, including the 17p TP53 mutation or VQ deletion, and also if you're going to choose the fixed duration therapy or continuous oral or intravenous. So the first question is, who should be treated patients with CLL? So if you go with the international working part of the CLL, we treat patients when you have an indication to treat. So when you have an active disease, those with advanced stages, stage 3B, stage 3 and 4, and Bennett C and Rye, stage 3 and 4, and when you have an active and progressive disease. So not all patients needs to be treated, and some patients we can observe, we can put them on which and what. And recently there is studies going on regarding the use of BTK inhibitors in those asymptomatic patients, and we can discuss that during the Q&A session. So this is the question now is, the second question is do we really, can we really use the chemotherapy in 2024? And there is still a place for chemotherapy. I'm just gonna get you back to the old MD Anderson study, FC300, and with a median follow-up of 19 years, the median progression-free survival for those patients with a mutated HV approaching 14.6 years, and compared with only 4.2 years for patients with unmutated gene. And also the disease progression after 10 years are very rare, and only 4 or 5 patients in those with a mutated IVIG were progressed. And I like this, an editorial was published just recently, and when you compare the old FCR with the novel therapy-based approaches, venetoclax-based or ibrutinib-based, look on the curve using the FCR. So the curve is flattening, and we can say this is a functional or potential cure for patients with CML, with the CLL, and those patients are young, fit, carrying the mutated IVIG status. So don't forget, this is not a good approach for patients with a bad risk features, for those with deletion 17p or P53 mutation, because the median progression-free survival for those patients is only 11 months, and the overall survival only 33 months. But how to compare the result after 20 years of follow-up for those received FCR versus those received venetoclax, fludarabine-based with like 5-6 years follow-up? So what's the preferred or the best option used frontline? So sure, these with BCL2 inhibitors and BTK inhibitors were the preferred, probably the preferred frontline agents in most of clinical scenarios, with the exception of the use of chemoimmunotherapy in the small fraction of patients, those with a fit, young, with mutated IVIG. So what BTK inhibitors we know till now? We have 4 BTK inhibitors approved for a frontline and relapse refractory setting. We have ibrutinib, acalabrutinib, zanubrutinib were approved by FDA, approved by FDA for frontline and relapse refractory setting, and the pirtobrutinib was approved after failure of 2 lines for those with relapse refractory CLL. So what's the difference between all of these? Probably, I'm going to show you the result of phase 3 trials. The efficacy of all of these agents in the frontline were similar, but probably with a different safety profile between all of these agents. So this table, sorry for the busy table, but what I wanted to show, there is multiple phase 3 trials that were published and proved the benefit of continuous first-line BTK inhibitors and ibrutinib and acalabrutinib in one of the studies with a reasonable follow-up time, with sustained, durable, progression-free survival and overall survival benefit in most of these studies. So I'm going to go through some of these studies just to show you what are the criteria and what is the benefit, what's the result of these studies. So the first one is the RESONATE-2 study evaluating the use of continuous ibrutinib frontline compared with an old drug chlorambucil. And as you can see, this study included patients more than 65 years untreated without 17p deletion. And this is the updated efficacy at 8 years. And as you can see on your right hand, the 7-year progression-free survival for those 60% versus 9%. And on your left-hand side, if you look on the overall survival, so at 8 years, 78% of patients received ibrutinib continuous, and the median overall survival was not reached. And when we dig deep to the deletion 13 and the IVIG mutational status, again, the benefit at 7 years were in favor for the use of continuous ibrutinib compared with the old standard chlorambucil. And as you can see from the subgroup analysis, all of patients, regardless of the age, gender, stage, and acute performance status or bulkiness of the disease, and baseline characteristics also, some of patients were p53 deleted patients, all benefited from continuous use of ibrutinib when compared to chlorambucil. And as you can see, the responses is high. Objective response is 92% versus 37% in those who received chlorambucil. And as you can see, the CR is progressively increasing with time. So when you give ibrutinib for a longer period of time, you're going to reach more, you're going to get your patient or more patient into CR. This is a study comparing also the continuous use of rituximab with ibrutinib versus the old standard FCR. And this is in a younger than 70-year-old. This is an ECIG 1912 study with a 6-year follow-up. Again, from the graph you see on your left-hand side, so the continuous use of ibrutinib with rituximab improved the 5-year progression-free survival compared with the old FCR. And also in those patients with unmutated LOC, the improvement in 5-year survival from 33 to 75%. And also the earlier result of the FLAIR trial also proved the benefit of the use of continuous ibrutinib in combination with monoclonal antibody, CD20 monoclonal antibody. So the median overall survival was not reached compared with only 66 months in those patients received FCR. Of course, there is not much of different. There is a different even in those with mutated. Even ibrutinib, rituximab improved the patient with a mutated IVIG status. And this is the overall survival, look on the 5 years of survival using the ibrutinib rituximab. So 5-year survival 95% versus 89%. And regarding the safety profile, patients who received ibrutinib rituximab got higher risk of hypertension. These are the usual stuff of cardiac toxicities from ibrutinib, infection a little bit to do comparable, and the cardiac events, including atrial fibrillation, in 4.5% versus 0%. So more cardiac events with the continuous use of ibrutinib compared with the FCR with more neutropenia, more neutropenic fevers. This is the third, the Alliance study also compared the ibrutinib plus minus rituximab with the bendarituximab. And as you can see also, the use of ibrutinib continuous with or without rituximab improved the progression-free survival with a hazard with a 4-year survival of 76 compared with 47%. So here you use ibrutinib alone or the rituximab, the results were in favor of compared with chemoimmunotherapy. The last eliminated study also compared the obinutuzumab with the ibrutinib compared with the chlorambucil obinutuzumab. Again, the median overall survival was follow-up was 40 months. The objective response were high, 88% versus 73 with higher complete remission rate. And at last update at 42 months follow-up, the progression-free survival was 74 versus 33%, but there was no difference in overall survival. And we're getting ibrutinib with obinutuzumab. Of course, it is better from your left-hand graph. Those patients benefit from the use of ibrutinib and obinutuzumab combination. So I'm going to show you the update from the ASH 2023. This is for patients using or used ibrutinib, only ibrutinib, and they followed them annually with for the first 5 years with the CT scans and the clinical examination, and they followed them also for MRD, and the primary endpoint was progression-free survival, and the secondary was overall survival. And as you can see, those are high-risk patients included. They compared it with the high-risk patients, including P53. And as you can see from your left side, the CR rate was, I think, 21 versus 27%, and the depth of response was increasing with the longer use of ibrutinib. So when you use continuous and ibrutinib for a longer period of time, you can get your patient into more CR, and you can get him into deeper response. And this is the progression-free survival. The median was 85.9 and 9. And also on your right side, the survival of the ibrutinib front line for those with the P53 mutation. Look at overall survival at 117 months, 58 months for all patients, 74 for treatment naive versus 54 for relapse for those with a P53 mutation. So longer use, the longer follow-up for those patients who received the ibrutinib still proved the benefit of using BTK inhibitors over chemoimmunotherapy. This is again the study, the ELEVATE study, the use of acalabrutinib with or without obinutuzumab versus the old chlorambucil with monoclonal antibody in a previously untreated patient. They randomized patients less than 65 and more than 65 with a SIR score more than 6 and the creatinine clearance of less than 70. So these are high-risk patients. They randomized them to acalabrutinib versus with ibinutuzumab versus single-agent acalabrutinib versus the old standard chemoimmunotherapy. And the primary endpoint was progression-free survival, and the crossover also allowed when there is a different disease progression. And these are the baseline characteristics of patients. Roughly 40 to 45 patients had high-risk cytogenetics and stage 3-4 disease, and in P53 mutation was present in 10% of patients. And this is the PFS at a longer follow-up at 6 years. You can see the median progression-free survival was not reached in a acalabrutinib arm with or without monoclonal antibody, compared with only 27.8 months for those who received chemoimmunotherapy, with 6-year PFS of 84% compared with only 25%. Unlock the 6-year PFS, 78% compared with only 17%. And those who were crossed over when they progressed, look on the PFS, 54%. So this is again to show the PFS in patient with p53 mutation and according to the treatment arm. So those who got acalabrutinib, they get improved progression-free survival, as you can see from your left-hand side. And sorry for that unclear scheme. So this is the update from the ASH 2023. As I did mention, the median survival 87. There was no much of difference between all of the treatment arms, but those with a p53 mutation, they got benefit from the use of acalabrutinib. And this is the side effects, the common adverse events, and the serious adverse events from the patient used acalabrutinib versus chemoimmunotherapy. And most of the common adverse events were generally consistent with the previous data, previous result analysis, and the incidence of cardiac events, atrial fibrillation, and infrared remains very low. So this is one of the drug that's compared, when you compare it with the safety profile of ibrutinib, it's more favorable, has a more safety and favorable profile. This is the zanubrutinib data also used in the front line. Zanubrutinib versus chemoimmunotherapy, bendarituximab in patient previously untreated. They have two cohorts. One cohort, the first is without 17p deletion, and the second cohort with the 17p deletion. And they're randomized to zanubrutinib as single agent continuously versus bendarituximab. And the second cohort, they're just randomized to, no, they get only zanubrutinib. And the primary endpoint was progression-free survival. And as you can see, the zanubrutinib improved progression-free survival. And at 4 years, 82% were disease-free compared with 50%. And those patients, when we compare those with mutated or unmutated IgHV, and to overall population, those who got zanubrutinib, regardless, they get benefit compared with patients who received chemoimmunotherapy. And this is the overall survival. So at 4 years, 90% versus 80%. And again, there is no safety signals from the use of zanubrutinib in those patients. This is the CLL14 trial using the fixed duration. So we talked about continuous use of BTK and compared with chemoimmunotherapy. And now we're going to discuss the use of fixed duration first line of ibrutinib with venetoclax or chlorambucil. And this is the safety run-in phase. They randomized patients untreated CLL with coexisting medical conditions, high-risk features, high-risk profile, the cells more than 6, and the clearance is less than 70. And they randomized them to venetoclax and ibrutinib. So it is a 4-week cycle to fixed duration of 12 cycles of venetoclax, over 5 weeks, combined with obinutuzumab, and the chlorambucil also was given to 12 cycles, and the monoclonal antibody was given only for 6 cycles, and the primary endpoint was PFS. And as you can see, so those patients, they got 12 cycles, 1 year of therapy, and they randomized them, and look on the progression-free survival, there was an improvement in PFS in those patients who got the venetoclax-based therapy. But on the right side, you see there was a trend, but there was no survival. There was a trend in improving survival, but it was not statistically significant. Those patients with mutated IgG were improved their PFS, and those with no mutation or no deletion of TP53 also had an improvement of progression-free survival. So also another secondary endpoint for this study is the MRD. And those who got an MRD of less than 10 to the minus 4, they had an improved survival from the use of venetoclax fixed duration with obinutuzumab. So this is the CLL13 trial, also the use of fixed duration of venetoclax with anti-CD20 monoclonal antibody with without ibrutinib, so what's called the triplet therapy. They randomized fit patients, CLL, with less than 6, clearance more than 70, and no previous therapy for CLL. Of course, here there is no p53 mutation or 17p deletion. They randomized them to the triple therapy of ibrutinib, venetoclax, and obinutuzumab versus venetoclax, ibinutuzumab, venetoclax, rituximab, or the usual conventional old standard of chemoimmunotherapy. And these, the primary endpoint was the MRD negativity. It is less than 1 cell in 10,000 leukocytes analyzed. So those patients got fixed duration, again, 1 year of therapy, compared with chemoimmunotherapy of like only 6 cycles. And when you get to the primary endpoint, the MRD comparing venetoclax, obinutuzumab, compared with chemoimmunotherapy, there was an improvement in MRD negativity from 52 to 86.5%. And also when you get to the triple therapy using the ibrutinib, venetoclax, obinutuzumab, and you compare it with chemoimmunotherapy, also still the MRD was significant and improved from 52 to 92%. So at a median observation time of 50.7 months, compared with chemoimmunotherapy and rituximab venetoclax, still those patients who got triple therapy or got venetoclax-based therapy, they had an improved progression-free survival and overall survival. This table showing also the fixed duration on the use of venetoclax with BTK inhibitors. And what I wanted to show you, look on the undetected minimal residual disease at a reasonable follow-up time with an improvement of objective response and PFS, and in some of the studies, overall survival. So there are lots of studies. I'm going to discuss 1 or 2 studies regarding the use of combination of BCL2 inhibitor with BTK inhibitor. And this is the Captivate study using chemotherapy-free fixed duration regimen and 4-year follow-up for those patients who got fixed duration. This is not randomized, the fraction of patients. 159 patients, they got to 12 cycles of ibrutinib venetoclax after giving 3 months of ibrutinib. Sorry?
Dr. Khalid, you have 2 minutes more?
Just 2 minutes?
Okay.
Then I will skip some of the slides. Okay, and they followed them, and upon progression, they got salvage therapy. So this table showing the patient who progressed and patient who didn't progress. As you can see, in patient with CLL with disease who progressed on this therapy, the risk factors were comparable with more in those CLL patients who progressed in therapy. And look on at a median follow-up of 57 months, those patients with unmutated IGHG had a 70% PFS, and the progression-free survival were improved across most of the high-risk patients. So I will skip these slides. And again, this is the GLUE trial 4-year follow-up, also showing the improvement in progression-free survival and those with unmutated IVHG. This is the last, if you allow me just 2 minutes, just elaborate on this in an experimental approach of patients using therapy based on MRD. So the first study we know that was published previously, continuous use of ibrutinib rituximab compared with chemoimmunotherapy improved the PFS, and the FLAIR follow-up trial comparing the ibrutinib venetoclax compared with FCR. Again, 6 months of therapy for FCR, and these 2 to 6 years of therapy with venetoclax ibrutinib. And this is the UK data. They decided to give those patients more extra 2 years after being MRD negative. This is the characteristics of patients, and these are the risk profile for those patients. And again, just one thing to say, at 9 months, you see the ibrutinib venetoclax, 60% of patients get into CR, CRI, compared with the 50%, and even any time during therapy, the 92% got into complete remission compared with the 70%. And in your right side hand, one thing to say, those patients with mutated IgG, at 2 years, only 39% got into MRD negative, compared with more than 50% of patients with unmutated IgHV. Again, there is an improvement in progression-free survival of ibrutinib venetoclax compared with chemotherapy, and there is also an impressive overall survival in this trial in particular. Regarding the safety signal, again, the usual classic, and there is no new signal, safety issues. And with this, I would conclude. So chemotherapy might be still an option in a small fraction of patients, especially in our region. So upfront BTK-based therapy resulted in sustained PFS and OS compared with chemotherapy. New BTK inhibitors have comparable efficacy profile with better safety data. And achieved of undetectable MRD is not a requirement for long-term disease-free survival based on the long-term 10-year follow-up. A prior treatment, P53 and unmutated status impact the prognosis. So fixed duration therapy might be a better option for young fit patient, and high-risk patient deletion 17 P53 mutation treatment is still unclear, and the MRD guided approach is still experimental, but we can use it to decide on the duration of therapy, especially for those young patients. And with that, I would conclude. Thank you very much.